Welcome to The Explainer. Today we are going on a journey from the lab bench right to the patient's bedside to talk about a really key zoonotic pathogen, Pasteurella multocida. For any of us in the clinical microlab, this one's a classic, and knowing it inside and out is absolutely crucial.
So let's start with a scenario, because this one is practically textbook. You get a call about a patient with an animal bite, especially a cat bite, and the infection is just exploding. We're talking intense pain, swelling, all happening way faster than you'd expect from a typical staph or strep infection. That incredibly rapid onset, that's your big clue.
And the answer, of course, is Pasteurella multocida. It's a bug that lives totally harmlessly in the mouths of the vast majority of cats and a lot of dogs too. The problem is, an animal's sharp teeth are like a perfect little needle injecting that bacteria deep down into the tissue, where it can cause some serious trouble.
Okay, so let's head into the lab. The swab from that bite wound has just arrived. Time to get to work, and our investigation starts, as always, at the microscope.
So you get it under the oil immersion lens, and what do you see? These small gram-negative coccobacilli. But the real giveaway, the thing that makes you go, aha, is that classic bipolar staining. The ends of the cell grab the stain more than the middle, giving it this beautiful safety pin look. It's one of those morphologies that just screams the answer at you.
Now what's really cool is how its growth patterns help us narrow things down almost immediately. It grows perfectly well on your enriched media like blood and chocolate agar. You get these nice, smooth gray colonies. But the critical piece of the puzzle is on the right. It does not grow on MacConkey agar. That one little fact instantly separates it from that huge family of gut bacteria, the Enterobacterialis.
Next up, we run the biochemicals to get that definitive profile. First, it's oxidase positive. That's another big check mark against it being an Enterobacteriale. It's catalase positive. And here's the fun one. It's indole positive, and that's what's responsible for this really distinct kind of mousy or musty smell you get from the culture plate. You add in that it's non-modal and urease negative, and you've built a biochemical fingerprint that is super specific for Pasteurella multocida.
So we've got a really strong presumptive ID from our classic workup. Now we turn to the modern tools for the final confirmation and, just as important, to figure out which antibiotics are actually going to work.
And while that classic workup is great, these days, the absolute gold standard is molecular. We can run a species-specific PCR that targets the KMT1 gene. It's incredibly fast, super sensitive, and it gives you an unambiguous yes or no answer, often way quicker than the old methods.
You know, this slide is a perfect example of how much our field has evolved. We've moved on from these really clunky, often unreliable methods like Heddleston serotyping. It was a ton of work and you needed all these special reagents. The modern standard is to just go straight to the source, the DNA, using things like LPS-MPCR to genotype the strains. It's just way more accurate, faster, and better for tracking outbreaks.
Okay, once that ID is locked down, we have to report out the susceptibilities. And it is absolutely vital that we use the correct organism-specific breakpoints. Just look at this EUCAS table. Pasteurella multocida has its own dedicated list of MIC breakpoints. And check out that number for penicillin, a breakpoint of 0.5 milligrams per liter. It's ridiculously susceptible. Reporting against these values is what allows clinicians to use the right drug.
And that brings us right back to the bedside. With our confirmed ID and a full susceptibility panel in hand, the lab's job is now to help the clinical team make the smartest possible treatment choices.
The international guidelines, like the ones from IDSA, they follow a really clear logic. See, animal bites are a dirty polymicrobial mess, so you have to start broad with something like amoxicillin clavulinate. That'll cover your Pasteurella, your staph, your strep, your anaerobes, but, and this is the beautiful part, once we call from the lab and confirm it's Pasteurella multocida, the best practice is to de-escalate. You narrow that therapy right down to simple, targeted penicillin. It's the perfect drug for this bug.
So that's the general international approach. Now let's compare that with some more specific guidelines, first taking a look at the recommendations from the Netherlands, and then digging into the unique challenges of treating kids.
The Dutch guidelines from Swab give a really clean, pragmatic playbook for primary care. You can see their first choice is the same, amoxicillin clavulanic acid for 5 days. For a patient with a penicillin allergy, the go-to is doxycycline. It's just a very clear, effective, empirical strategy.
Treating children, though, that throws a real wrench in the works. Doxycycline, which is our easy answer for adults with a penicillin allergy, is generally a no-go in kids under 8 because of the risk of tooth staining.
So that makes treatment a real challenge, and it often means you have to use a combination of other drugs. Honestly, this is exactly the kind of situation where you really want to get a pediatric infectious disease specialist on the phone.
You know, our job doesn't just stop when the report goes out. As microbiologists, we actually have a really important role in the bigger picture of infection prevention, both inside the hospital and out in the community.
And when it comes to animal bites, prevention starts with wound care. This is probably more important than any antibiotic you can give. Step 1 is immediate and forceful irrigation. You gotta mechanically wash those bacteria out. Step 2, clean out any dead tissue. And step 3 is absolutely critical. For deep puncture wounds, especially from cats, do not stitch them closed. Suturing a contaminated wound just traps all that bacteria inside and creates the perfect little warm anaerobic environment for a nasty abscess.
This quote really nails a vital point. Bites are the classic way to get this infection, but you can get severe invasive Pasteurella disease without any bite at all, especially in people who are immunocompromised or have liver disease. Sometimes just close contact, like a pet licking someone's face, is enough. The clinical history has to include the question, do you have pets?
And finally, we have to remember to protect ourselves. Pasteurella multocida is a BSL-2 pathogen. That means we follow standard precautions, we wear our PPE, and anything that could create an aerosol has to be done inside a biological safety cabinet. We have to respect the organisms we work with every day.
We put this entire explainer together using Gemini Deep Search. If you want to dive into all the articles and guidelines we used, you can check out the complete notebook document. And hey, if you found this helpful, please hit that subscribe button for more explainers like this one. We'd also really love to hear from you, so leave your feedback and questions down in the comments.
So, I'll leave you with a final thought to chew on. Pasteurella multocida is famous for being super sensitive to penicillin, but rare strains that produce beta-lactamases have been reported. As antimicrobial resistance keeps growing, how might that change our strategies for what's always been a pretty straightforward infection to treat? Definitely something to keep an eye on. Thanks for watching.